した方が。No. Okay, let's start. So yesterday I told about the custom fit TKA. This is a very, very new concept. It is completely different from mechanical alignment TKA. This purpose of this TKA is just to restore the patient native or pre-disease articular surface. So using the PSI. Then now it is evolved to the kinematic alignment TKA. It is very widely known. It's very popular. It's a kind of a boom of a new concept of total gas plastic. So why kinematic alignment? So kinematic means the movement. So aligned to the movement of the knee. What is the movement? There are three types of movement in terms of the knee kinematics. The first is the flexion extension motion of the femur on the tibia. And the second one, the patellar movement on the femur trochlear. And the third one is tibia rotation. It is a longitudinal rotations. So this is the three axes. The first one, the green axis, is the flexion extension axis. In the kinematic alignment TKA, the flexion extension axis is cylindrical axis. That is the line between the center of medial condyle and center of the lateral condyle. We call it cylindrical axis or condylar axis. It's a little bit different from the epicondylar axis. Epicondylar axis is insertion of MCL and PCL. LCL. But cylindrical axis is the center of the condyle. Because condyle is simulated as the circle, especially between the 30 degrees flexion to 120 degrees flexion. So that is the green ones. And second one is the patellar axis. It is parallel to the green line, but a little bit proximal and anterior, and a little bit wider. And the third one is the yellow line, is the tibial rotation longitudinal axis. So it implies the medial pivotal motion because the tibia rotate around this yellow line. So as a result, the tibia movement is rotate. During the flexion, tibia rotate, what can I say, internally. And then in flexion, extension, tibia rotate externally. So kind of so-called screw hole movement. So aligning to this line. So theoretically, kinematic alignment TK, in the kinematic alignment TK, we should use single radius component and medial pivot component. So this is the Metacuta Jim case here. That is a true medial pivot motion, medial pivot component. So medial side is virtually ball in socket, like THA, and the lateral side is virtually flat. So for this single radius component makes this cylindrical axis is a component, and this ball in socket joint. So perfect conformity of the medial side. So allows the tibial rotation in the medial, around the medial side, so-called medial pivot motion. So this is a kinematic alignment. So as a result, So first, sorry. So this kind of TK is just replicate the native joint surface, but concept is a little bit different, changed in the kinematic alignment TK. So as a result, if we replicate the patient native joint surface, this movement can be induced automatically. But in fact, due to some reason, one reason is ACL sacrifice, and other one is difference among the patient, the characteristic of the kinematic. So to stabilize the kinematics through the flexion extension around this condylar axis and the rotation of the tibia around this line, medial vertical line, so-called medial pivot motion. So this kind of component induce such perfect motion. So anyways, to how to perform the kinematic alignment TK, the purpose is to duplicate this cylindrical axis using the component. So use the calibrated kinematic alignment TKA. So now the previously in the first this kinematic alignment is performed using PSI like custom fit TK, but now it is performed using the manual instrument. So the concept is cut the same thickness as component, compensating for cartilage wear. Okay, so this is distal femoral cut put on the paddle on the distal surface of the femur. If the patient has the intact cartilage on both medial and lateral condyle, we cut just 9 millimeter and 9 millimeter. In most component has 9 millimeter thickness of distal thickness and 9 millimeter of posterior thickness. But on the metacuta have the 8 millimeter of posterior condyle. But it doesn't matter, we can adjust it. So anyway, we put on the paddle on the distal end of the articular surface. If the patient has the medial side cartilage wear, the amount of cartilage is estimated as around 2 millimeter on the cartilage thickness. So in such patient, kind of paddle, the medial side is 2 millimeter thicker than the lateral side. So 2 millimeter difference is equivalent for the cartilage thickness. So put on the paddle and then cut. So if we use the medial side or kinematic paddle, so call it worn and worn. Worn means one side the 2 millimeter thicker, compensating for the cartilage wear. And the unworn side is a no compensation. So there is a 2 millimeter difference. The put on and cut. As a result, lateral side should be the 8 millimeter because we set the cutting block for the lateral side as 9 millimeter. But saw blade thickness is around 1 millimeter. Actually 1.32 millimeter, but roughly saying 1 millimeter. So 9 millimeter minus 1 millimeter equal 8 millimeter. That is fine. That is perfect. And lateral side. How about the medial side? medial side, the target thickness is 7 millimeter. Because 2 millimeter of cartridge is already gone. So it should be the same millimeter, but so blade thickness is 1 millimeter. So 1 millimeter should be is deleted from the thickness. So as a result, medial side should be the 6 millimeter. 8 and 6. That is the perfect. Okay, that's it. How about the posterior side? And most patient has the intact posterior cartridge on both medial and lateral condyle. So in such patients, so sizer or femur sizer, put on the femur sizer and adjust the rotation as 0 degrees. And measure the size and make the drill for fix of the 4-in-1 cutting die. So for the mechanical alignment, so our rotation should be adjusted as 3 degrees or 5 degrees. Do you understand? In the normally mechanical alignment, this size should be adjusted as 3 degrees in rotation, external rotation. But kinematic alignment rotation angle should be 0 degrees, the parallel to the PCA. But some patients have the already cartridge wear on the medial on the lateral side. It's for such patients, so we should adjust the rotation, or we should put some metal plate that is equivalent for the cartridge thickness on the paddle on the posterior. Anyway, so femoral rotation should be parallel to the PCA posterior axis. So that means that we will cut the same thickness as a component, both medial and the lateral side. So in a normally, some of the posterior condyle cartridge are very normal, so we need to compensate for the cartridge wear. So cutting thickness should be the 8 millimeter and 8 millimeter both sides. If the cartridge wear is already seen on the medial side, so cutting thickness should be the 9 and 8 and 6. But in most cases, so posterior cartridge intact. So after the posterior cut and measure the thickness, it should be 8 and 8. That is ideal. But sometimes due to some reasons, so one is the inaccurate placement of the paddle, or saw blade skiving. Skiving means that, what can I say, it's a curve of the saw blade on the hard bone. So this cuttingness is thinner or thicker. So normally, so cartridge wear side, it tends to be thinner in terms of the cutting thickness due to the skiving on the hard bone. But lateral side is all patient has a normal. So lateral side thickness, cutting thickness is maybe accurate in most of the cases, but medial side we should take care the medial side, because that is sometimes too thin because of the hard surface of bone. Okay. Anyways, so I will continue my talk in the Friday. OK?
効果の内側の後ろが硬い。
効果は大丈夫なことだけど、前方が硬い。前が硬い。効果はどっちかというとパドルが正確に合ってないことが多い。